A small screening swab rests inside a plain tube. The sample can be taken in private with a small swab. The laboratory can look for the virus that causes almost every case of cervical cancer, but the person who needs the test never hears that it is time. In August 2026, a review found that almost 1 million notifications had not been sent from New Zealand's new cervical screening register to eligible people. The review made 48 recommendations, including an urgent search for people who had not been screened. That failure reveals the central idea of this story. A national screening program is not only a good medical test, it is a public promise to remember people before they become patients. New Zealand learned that lesson through a painful history. In the 1980s, an inquiry led by Judge Sylvia Cartwright examined the treatment of women with abnormal cervical cells at National Women's Hospital in Auckland. It found failures in treatment, ethics, and respect for patients. The inquiry reported in 1988. New Zealand established its National Cervical Screening Program in 1990. The program was designed to do something that an ordinary visit to a doctor could not do on its own. It would look across a population, record who had been screened, and help make sure abnormal results were followed. The history did not end there. About 10 years after the Cartwright inquiry, another inquiry examined cervical screening in Gisborne. A laboratory had failed to identify hundreds of abnormal smear tests. The people affected included a high share of Maori women. Those events shaped an unusual legal safeguard. The National Cervical Screening Program is the only national screening program in New Zealand with its own detailed framework in the Health Act. Part 4A covers the register, the use of information, independent evaluation, and regular review. This is why a register does far more than hold names. It is part of the safety system. Screening itself has changed greatly. For many years, the main test involved a clinician collecting cells from the cervix and looking for cell changes. People often called it a smear test. In September 2023, New Zealand moved to primary testing for human papillomavirus. Some types of this common virus can remain in the body and cause cell changes that may later become cancer. The first question is now whether a high-risk type of the virus is present. For most people, the sample can be collected with a vaginal swab. They can take the sample themselves at a health clinic behind a closed door or ask a health worker for help. A clinician-collected cervical sample remains another option. The self-test matters because the old process could carry pain, embarrassment, fear, cost, travel, or memories of bad care. Changing the test lowers several of those barriers at once. The early numbers showed how strongly people responded. From the national launch to the end of February 2026, more than 895,000 primary human papillomavirus screens were completed. More than 4 out of 5 were self-tests. About 1 in 6 screens came from people who had previously been unscreened or underscreened. Overall coverage rose from 67% before the change to 75.5% by February 2026. The gap also narrowed for Maori and Pacific people, although coverage was still not equal across every community. The weakness inside that progress is easy to miss. A simpler test opens a door. The register must still tell people that the door exists, when to walk through it, and what happens next. A negative result usually allows a much longer interval than the old smear program. For most people, routine screening moves to once every 5 years. That convenience makes reliable reminders even more important. 5 years is long enough to move house, change a phone number, change a general practice, or simply forget the date. A positive human papillomavirus result does not mean a person has cancer. it means the pathway must continue. Depending on the virus type and other findings, the next step may be a cervical sample, another test, or a closer examination called colposcopy. Now the register is doing two kinds of work. It must find people before a test, and it must keep hold of the thread after a result. One missed message may sit at either end of that pathway. The number from the review can sound strange because almost 1 million notifications does not represent almost 1 million different people. One person may be due for more than one invitation, reminder, or follow-up message. The scale is still serious, but the unit matters. It also explains why sending every missing message is only one part of the repair. The system has to know which people are truly due, which contact details are current, which messages failed, and which clinical step each person needs. A rushed message sent from poor data can create new confusion. The most useful lesson for everyday life is simple. Silence from a national program is not proof that no action is needed. New Zealand's routine program covers women and people with a cervix from age 25 to 69, with some later screening in particular circumstances. Anyone who is unsure can check with a general practice, a screening provider, or Health New Zealand. That is a practical step, not a reason for panic. The long story of cervical screening in New Zealand is often told through laboratories, laws, and new technology. Its real subject is memory. The swab can find a virus, the clinician can examine cells, the law can demand review. Only a working program can connect those moments across years and across changes in a person's life. The promise hidden inside a reminder is only 6 words long. The health system noticed your absence.